Hello and welcome to Series 3 of the Borne Podcast, the podcast that brings you stories of research, resilience and real-life experiences of pregnancy and preterm birth. I'm Ellie Gibson.
And I'm Caro Tasker.
And I'm Mark Johnson. As an obstetrician, I've seen the devastating effects of preterm birth, how challenging it can be for families who are going through that, and the extraordinary strength shown by parents. And I believe, because I'm a scientist, in the progress that can be made through research. And it is that belief that led me to found Borne in 2013, to better understand pregnancy, to find ways to prevent preterm birth before it begins.
At Borne, our aim is to prevent preterm birth, giving every baby the best possible start in life. We fund pioneering research to deepen our understanding of pregnancy and childbirth, research that brings us closer to answers and realising our aim to prevent preterm birth.
In this podcast, we bring together parents, experts and scientists to share their stories with honesty and compassion. We talk about the science, but we also talk about hope, heartbreak, courage and the small victories that mean everything. Because every insight, every conversation and every breakthrough moves us towards a future where more babies can arrive safely at the right time.
So it's a great pleasure to welcome Professor Lucilla Poston. Lucilla is our new chair of our Scientific Advisory Board for Borne. It's the board who assesses all the applications that come through each month, each year, each how often, don't know, whenever they come through. And Lucilla will tell us whether they're good, bad, or frankly indifferent. And that way we get to choose the best science for Borne to support. So Lucilla, tell us, what attracted you to Borne?
Borne is a very good charity. It's working on one problem in pregnancy, which I think is really important. I've worked with other charities before which sort of have a different group of outcomes to think about, gestational diabetes, hypertension and so on. But I think the focus on prematurity is what really attracted me. And also having worked in obstetrics and pregnancy complications for almost as long as I can remember, prematurity is the most difficult nut to crack. And it's something that I really think if we work hard and we focus on, we're going to get there.
Yeah.
So that's why I joined Borne.
Yeah, I mean, it's a great pleasure to have you as part of Borne, honestly, because you are, top 100 in the UK, top 1,000 in the whole world. And if you think about that, that's in all female scientists. So you are probably honest to say, the top scientist working in pregnancy today in the UK.
One of them. Very, very good. Very good.
Badge or a
Lucilla's
certificate
also-
for that? A very strong record. I feel like there should be a T-shirt at least.
I think it means Borne is getting the best opinion to assess research, and that is really, really important for us at Borne to know that we are supporting the best research that we can support.
Since I've arrived, we've made the choice of projects really quite sort of transparent, and I've appointed a board of super good people, and including some very good top scientists, female scientists, across from the UK and the USA, and scientists and clinicians. And so we have a group of people who cover a lot of the different aspects of premature birth, who are expert in their own way. So when we have an application to consider, I have a group of experts who I can call on for their opinion. I just put their opinions together. That's what my job is. I take the information that they give when they've read it, and we sort of synthesize in a way which we think is going to tell us the best research. And it's working really well now. I think you agree, Mark. We've got a good group of people.
And also you read it in great detail and have good opinions as well. So, I mean, I think we're just very, very lucky. I'm very happy to have you here, I have to say.
That's very kind of you. It's very nice to be with you.
Can we talk about your career and how you got started? What was it about obstetrics that made you want to work in that field?
Well, I didn't start in obstetrics at all.
Okay.
So I'm a scientist by training, and I did my PhD in medicine, but it was actually in liver disease, believe it or not. And then I was working in high blood pressure associated with liver disease, and then I became very interested in hypertension just across the board. And I became a cardiovascular physiologist for a while, which has been very useful actually for the work that I've been doing since. One year I was a lecturer at Guy's at St Thomas's Medical School, and into my lab came this very bright young Irish obstetrician And he said, Lucilla, he said, you're working on all these blood vessels in general hypertension, pregnancy hypertension. Nobody really knows what's going on. And I thought, well, that's fantastic. So I started working on the blood vessels in the placenta. And I became incredibly interested in the whole of obstetrics research then, because I realised there was a big gap in understanding. Whereas in sort of hypertension in the general population, people understood it, they could treat it very effectively. It was very poorly understood in pregnancy. So that's where I went into pregnancy hypertension first of all. And then years later, I became a professor in the medical school. And then I got a chair, which was funded by another charity. And then I was head of department. So I had a really big say in what was going on in obstetrics research. And that's when I started focusing on premature birth because it was really underexplored. And so we brought in some really good scientists and clinicians, and we got a big group together in premature birth. And so I was sort of the nominal head of that. Lots of very good people working with me. Then we also had hypertension in pregnancy work. So at one stage I was working myself both in hypertension in pregnancy and in prematurity. I come back to prematurity with Borne, which is, as I say, I think it's so important. And so it's not so much as it's under-researched. I'd say it was not properly researched in the past. There's been too much of a sort of rather amateur approach to it in some ways. And I think now the focus with Borne is really hard on science and the new technologies we have to offer.
But that said, we are obviously doing incredible things at Borne. How much further along are we from, say, 2 decades ago in terms of premature birth and understanding it and how we can prevent it further?
We haven't gone much further in being able to prevent it. We can predict it and we can treat its symptoms a bit better, but we can't necessarily really totally say if we got somebody who's at risk of premature birth, we can prevent it. That's not the case, but we can predict it well. Cervical cerclage and so on will help. Some of the tests like the fetal fibronectin test. I was there right at the beginning of the fetal fibronectin test. That was a very exciting period. The first work we did was probably about 20 years ago on fetal fibronectin. The first trial I did, clinical trial, was to get a group of people who were at risk of preterm birth on the basis of the fetal fibronectin test. So first study we did, and then we treated them with metronidazole, which is an antibiotic, half of them, and half of them didn't get it. And then actually we found that metronidazole didn't do any good. But that was the first trial I did, and that was using fibronectin as a risk screening tool, which was very useful. Then other tests have come in the meantime, so we're very good at that. But we still have the problem of not quite understanding what kicks it off. And now we're sort of realizing there are different sorts of spontaneous premature birth. So we're looking at increasing subgrouping and then putting people into different subgroups and understanding the basis of their
I would say that's probably the biggest advance that we've made, is to understand that there are different types. Now actually looking for the specific mechanisms in each type. And it's true to say, preterm birth rates remain static or are increasing around the globe. But we can give progesterone, which reduces the risk by 40%, stitches, which reduce it by 20%. So and the combination actually seems to work better than either alone. So we are a little bit further forward, and our understanding of when these things work best and when they make no difference is the problem. And of course we have aspirin, which reduces the risk of preeclampsia, which was your first home of high blood pressure, by 93%.
It's extraordinary.
So there are things that have changed, but stubbornly, the rate of preterm birth remains the same. Quite why that is a bit of a conundrum, and all other health parameters are improving. I mean, of course, I have my theories, and I'm sure you have yours as well.
We all have our theories. I mean, if you look at the study we've just done with big data, we have a big cohort of 45,000 women who've been looking at premature birth. We've just shown, for example, that people who see the same midwife all the time and who have that their appointments in the community, so they basically have more relaxed sort of pregnancy
continuity,
they have much less prematurity than people who don't. So there's the stress side of it, there's the environment, and I suppose also that the continuity of care means you pick up the symptoms earlier, and then you can look at high-risk women and see them more often. But that sort of thing tells you quite a bit about these. These are generally also people who have poor socioeconomic status and poor environment to live in, often stress in the home, living on their own and so on. We just done a study of migrants too, who have a very high prematurity rate. the sort of care that you get inevitably influences it. The ethnicity also influences it. So black people are more at risk of premature birth than Caucasian people. So there are all sorts of factors. There's the environment, there's the genetics, there's the ethnicity, and then there's this mechanism underpinning premature birth and the different sorts. So we have a lot to think about. It's a holistic approach to it that is really important, as well as the mechanistic understanding.
At what stage do we educate people about that? Children in school? Do we start speaking to them at what level? Because this is something that will happen to a lot of those people that are in school. So without wanting to frighten people and without wanting to take away from other areas of really important education, maternal and fetal health is extraordinarily important.
Yeah,
What stage do we start?
We start too late. I mean, there's no question about that. And that's one reason I'm a school governor now, and I'm head of the education committee for a school. And I love talking to the pupils because they really absorb it. They're really interested in it. And it's totally new to them. It shouldn't be totally new to them. So, you think that there's very little sort of general health education. And I gave a talk a few months ago to the sixth form. All the sixth form came. There must have been 200 of them, about the fact that if you're healthy when you become a parent, not after you become a parent, but working towards being healthy. So if you're thinking of having a family, focusing on your weight. I mean, obesity, for example, is associated with diabetes, associated with some sorts of premature birth. So just thinking about your own health and thinking that you're good. And I said, you're going to be parents one day. And they, they're boys and girls are sort of 18. But they took it in, and I had a group of them around me at the end of it, asking me all the right sorts of questions. I don't think they'll ever forget that lecture. It wasn't because it was a particularly good lecture. It was because it was new. I just couldn't believe they hadn't heard it before.
That's extraordinary, isn't it? That's extraordinary that we're leaving it quite late within the education system. And, I can hear people sort of saying that obviously there are very many different things that children need to learn. But you're right, a lot of them will choose.
The first I knew anything about premature birth was when I was looking at my 31-week-old baby in an incubator going, oh, blimey, I'm trying to remember that episode of Holby City. Do you know what I mean?
Yeah.
I was like, I didn't know anything about it. And I thought, oh, well, but it's okay because we're in a hospital and he's breathing. So we'll get to go home in 2 weeks. That'll be fine. And then it was a real part of my sort of trauma around it was a real car crash of having to learn all these facts and being in an environment where a lot of other people know the facts, but they don't necessarily have the time to explain to you everything because they're too busy saving lives. And it was just such a lot. Yeah.
And it doesn't surprise me that you were inundated with questions afterwards. They're 18 already. And that's extraordinary to me. I mean, if you think about women's health in general, it really should be within the sciences.
We're not looking at how people live their lives going forward. I mean, if we think that mental health increases the risk of preterm birth, we think poor diet increases the risk of preterm birth, and we don't even begin to address those problems in schools. No. And now we have initiatives
mental health problem, as we all know, has escalated. COVID did not help. But we have an awful lot of people of reproductive age, if you like to call that, women who are going to be parents quite soon, who have got awful mental health problems. I mean, serious mental health problems. And there's a question of diagnosis. Are we screening and diagnosing enough? No, probably not. And very often those things come to light in pregnancy because there are always questions when people come to book for pregnancy about antenatal depression, anxiety, and so on. And they often come out then for the first time. And then, of course, we work with a mental health trust, and a lot of women are referred because they have serious mental health problems. Mental health and the treatment for mental health is associated with premature birth. So, there's something that nobody ever talks about. But if you add that to all the physical problems that somebody may have, then you've got a sort of perfect storm in a way: ethnicity, obesity, mental health problems. And all of those associated with increased risk, depending on the ethnicity group, but with increased risk of premature birth. So we don't do enough risk assessment in terms of the sort of population health of people like that.
No, I agree. I entirely agree, because I think a lot of people don't know that they can actually ask for help as soon as they can as well. And this is why I sort of feel possibly there's an argument to have an entire module on women's health within the education system that everybody sits in.
Women
I
and
would get rid
boys.
of geography, to be honest. And just do
I went through a wonderful geography lesson.
Okay, all right. Is that corrected?
Actually, they do population health in geography now. I was pleased to say the whole module on it with the A level, which is very interesting.
What's your criteria for research when you are given so many studies coming forward? How do you decide?
People come to Borne, and so we have you go online. You say researchers apply here, so there's a form to fill in. So they fill in an initial form to just to see we're interested in what they're doing, broadly interested. So Borne is very interested in premature birth and mechanisms. So we really stick to that. So if it's out of brief, we just say no, sorry, and they haven't wasted much of their time. Then if we like it, then they'll write a big application. They can either do that for a small grant, which would be a sort of, initial pilot study or something for £50,000, or a big grant. So we get them in two different categories. And then when they come in, we decide who to send them out to for review. So we'll try and choose somebody who's not conflicted, who's not working with them, somebody who works in the same area anywhere in the world. But if you don't know them, you can search on, we have a wonderful scholarly website called PubMed, so you can pick up people who've written papers on any subject very easily. And we'll find some good people. Quite often some of the junior people are the best, actually, because they've got a bit more time to review. And we'll send them out, give them a few weeks to look at it, and then they'll send us a review back. And then we end up with 5 or 6 of these reviews, and we send them out to the Scientific Advisory Board, who are our colleagues who are helping us. And then we all sit down on a big Teams call and we mull it over. And so what you're looking for good science, of course. You're looking for science which is innovative, never been done before, or if it's been done before, it's been done badly, or, a new approach. So it's got to be novel, it's got to be top of the line stuff. Then you look at the methodology. Are they approaching the question in the right way? And sometimes they don't, because they're not using the most recent technology, or very often in terms of the design of a study, they might think they could do it in 10 people, where you actually need 1,000 people to do it in. So you have to think of the statistics of it. What is how many women do you have to look at to make this
What's your sample?
Statistically reliable? That's really important. It's what we call the power of the study. So if a study is underpowered and you get a result, you can't rely on the result. So that's where you bring in statisticians. So we have statisticians to our. So there's that, and then the cost. Is it realistically costed? And we much prefer it was realistically costed. So you have staff, which are the biggest costs usually. You have the consumable cost, the test tubes and the chemicals, and then if you're sending stuff off for genomics, or you can outsource a lot of the research, but it all costs a lot of money. Research is unbelievably expensive.
It's extraordinary.
We look at them all and we think, is that good value for money? Is that accurately costed? Are they using the best laboratories to do the analyses, or themselves? Are they using the best method? Are they proficient at those methods? Have they used them before? Are they trying to pick them up off the shelf, and will they be able to walk with them or not? So all the things that you look at people's CVs. Therefore, have they got a track record of having used those methodologies before? Have they been working in premature birth, or if not, have they been working in an aligned subject? So they have the experience to do it. So the curriculum vitae are very important. I always look at the papers they've published and see whether they're in good journals and whether they've done them properly or they haven't, And you can actually, for young people, you have to pick up people with the spark, and they may not have got a big track record, but the way they've written it and the prizes they've got, or the higher value degrees that they've got, that all gives you an idea. Quite often somebody will come and they've got prizes all the way through their early academic career, or they've gone out and got themselves small grants, which means they're hungry, for it. They're the people who are going to do the work.
So you're basically like the Simon Cowell of premature birth.
That's great. That's a great analogy. I like that.
Talent spotting.
See you and Mark there. Yeah. You and Sharon, Mark, obviously.
Clearly.
Can you give us some examples of studies that you have said yes to, that are going on at the moment?
I can give a few examples. So, I can give you one of Mark's studies if you like. Mark is doing a very interesting study, which is about...
Not krill again. Is it krill?
No,
it's like krill, but different.
Wait, there's a new krill?
No, this is to see whether giving women at risk of premature birth, if they take fatty acid supplements, whether it's going to reduce premature birth. And I was involved, and I was really interested in that when Mark applied, and he went through all the rigour of the peer review process. But I actually was involved in a sort of big collaboration collaboration who looked at all the literature. A guy in Munich led it, actually. He was an old chum of mine, and he got lots of people together. And we looked at all the literature, and actually the literature does suggest when you put it all together that it really works, but it probably works much better in people who are at high risk. So if you do a study in all comers, it's going to be diluted, the effect, so you don't see it. So Mark's study is in India, and it's looking at women who are at very high risk of premature birth. It's a really good population to look at because they are probably some of the highest risk, 20%, 22% premature birth. It's amazing. I mean, same in Africa, 20%. We've just done a study in Africa, 20% premature birth. Yeah.
Wow.
These are the countries that really need if we find something that works and is cheap, there is a massive burden of prematurity in low and middle income countries.
Yeah.
Terrible.
So then how does that work? So then you find women who volunteer for the study, or you ask women to get involved with the study?
So we ask women to get involved. We're going to measure the level of the DHA in the blood, and those people who have low levels, we're going to randomize them to either having a standard replacement dose of 200 milligrams, which is what everybody recommends now, or we're going to titrate it, so measure it again and again. We'll give them a dose of, say, 1,000 milligrams and see what their level is, and then we'll optimize it to get it to the right level, so we can
top
say,
it up. That's what you need to do. You need to get it above the level of deficiency.
And women are up for this generally? Women are kind of like, I'll do anything.
I did a cardiology phone session with a load of GPs, and I was supposed to be talking about heart disease in pregnancy, and I mentioned fatty acids and DHA, and I was inundated. Every single GP, all they did was ask me about fatty. They've got huge importance in lots of different areas,
because
but in our
it seems
area,
simple. I don't mean the research is simple. I'm not saying the research is simple.
It is potentially simple. I mean, we are looking for potentially simple solutions for populations like that.
That's an accessible.
It's very easy. It's like we used to say, when you stop the pill, start folic acid. Now what we need to say is, when you stop the pill, start DHA and folic acid. That will be success for us. It's 41% reduction in risk of preterm birth before 32 weeks. That's massive. Nothing out there does that.
And the right study, because when we were looking at Mark's project, he wasn't in the room when we were looking at it. When we were looking at it, the right study had not yet been done, i.e. in a high-risk population. And somewhere which was a very high rate of preterm birth, but where it was going to be most effective. So it's a very interesting study. Fatty acids are involved in development of the fetal brain, of course. So one thing that Mark will do is later on, when the children grow up, is to...
I was going to say, is this going to be a longitudinal study? You're going to carry it?
The cohort study.
Yeah. And that is something that would be applied for.
Yeah, and there is evidence that if you supplement babies that have been born, if mothers have been taking the supplement and yet they still have preterm birth, the babies are protected from the complications of preterm birth. So they have less cerebral palsy, less problems in the lungs, less problems in the gut, GI tract. So it's, even if you still get preterm birth and you've got enough DHA, you will do better.
God, it's absolutely extraordinary that something like omega-3.
Well, we hope. I mean, it's certainly not going to do any harm. That's the other thing.
Well, this is it.
This is the other thing you have to think about. When you're trying new drugs out, you can't try new drugs out in pregnancy, obviously, because we have the ethical issues. So it's extremely difficult to bring something new into the repertoire of pharmacy, because you just can't use it. You ethically won't be allowed to use it. It's one of the problems. You always have the issue with new drugs that it might affect the fetus. So if you want to get a drug into pregnancy use, you have to take it through a whole bunch of hoops. Can be done, but it's incredibly long-winded. You have to do it in some animals. You do it in vitro studies, and then you would need to take it on so single thing had been exhausted and found to be safe before you actually use the drug.
Of course.
And even then, I can imagine patients are quite nervous.
Oh, yeah.
It's a brand new thing, and that's.
What one hopes is that drugs that people are taking in the normal population might be useful in pregnancy, and in a way it's easier to get them into use. So, for example, the GLP-1s which are used for obesity, they're contraindicated in pregnancy at the moment. We don't know whether they will work or not. And
so is that the thing in drugs like Ozempic and things like that? Right?
So people are taking them to lose weight before they become pregnant, which again, in terms of premature birth, might be a good thing, but they are recommended to stop and cover them with contraception, because we have no idea at the moment whether they're actually harmful to the fetus or not. But I imagine over the years, this is what's happening already, people are continuing to take them when they're pregnant and don't know they're pregnant, because they, the first few weeks of pregnancy, which is slightly worrying. But there will be a series of women who've done that unintentionally, and then we might realise they were safe or not. We'd look at those women who've been taking them accidentally. But that's how sometimes drugs creep into use in pregnancy, that people inadvertently taking them don't realise they're pregnant. But that, it's not the best way. It's not exactly scientific way of doing it, but it's extremely difficult to get new drugs. And the drug industry, the commercial providers, are very reluctant because of potentially being sued.
Yeah.
It's a legal minefield. Developing new drugs for pregnancy, but ultimately we're going to have to do it, and we have to be prepared to go through those hoops to do it if we think there's something to be adequately tested and take it forward.
Is that your sort of great hope for preventing prematurity? Do you think it's about coming up with a drug at some point?
We don't know that, because what we're doing in the projects with Borne at the moment is delving really deep into the mechanistic side of it. And if we come up with something which might require a drug to manipulate it, that's what we would do. Yeah, that's what we would do.
I mean, I think the interesting thing about Big Bump, which is what Lucilla is referring to, is that we're going to be taking samples before the preterm birth happens, when we work out the mechanism, and then we can look backwards in the urine and blood samples to see if there's a biomarker that says this is the process which is starting, and then we can start preventing by giving treatment to those people who we think are at risk of this particular form of preterm birth. But until we understand the mechanisms causing it, and we find an effective biomarker to identify who is at risk, we won't really be able to give that focused preventative treatment. And we're going to have to do, treatment when somebody comes in again, like yourself, in preterm labour, but then diagnosing the mechanism or being able to identify the mechanism, which is another study which Lucilla could talk to about, called PROMPT, will enable us to give focused treatment.
Yes, I mean, it could be that it's not a drug. I mean, we don't know. I mean, it could be something as simple as a micronutrient like vitamin B12, or, I mean, the folic acid story is the case in point. It's incredibly simple to give folic acid, which is a naturally occurring. Folic acid is involved in the development of growth of the fetal cells, the fetal brain, the fetal spinal cord. I mean, we know how it works. We know every single bit of the pathway. So, it's a good candidate. And we also recognise that people didn't have enough of it, had more neural tube defects. So that was a sort of obvious one, but it was a naturally occurring product. So and many people in the population have high levels of it, and they're absolutely fine. So it's really good candidate. But it could be something like that. It might be something relatively simple, but you don't know until you know the pathway.
So as it stands, the project is the omega-3.
Well, we have several projects. Borne has got sort of multiple approaches to this. One is, as Lucilla was saying, can we find drugs which we can repurpose? Borne is funding a lot of studies on a drug called a broad spectrum chemokine inhibitor, if I can get it out, a BSCI for short.
So that's a study which has been going on in the United States. Well, very well respected professor has been doing the work, and that's the sort of thing we know his background. He knows he's been extremely successful. He's an extremely good scientist and clinician. And he's already done some studies in rodents which have shown really impressive effects. So if you induce premature birth in a rodent through infection with the product of bacteria, then this inhibitor, it blocks it completely.
Wow.
Yeah.
Because that's
really,
as far as it happened to me. I got an infection and then...
Yeah, well, this is infective preterm birth.
Wow.
This is where you have to show the safety of, treating that infection and keeping the baby in utero when you don't really know what's happening. You may cure that by the infection, but there is some harm, the residual bacteria or whatever, and we don't know. So that a lot of what he's doing is just following up the offspring of these animals. So that's what we've funded, is to put this drug in, but we're using it with another compound, aren't we? We're using it with an anti-inflammatory.
Yeah, so I mean, the two bits we're doing, one is with in an infection, ureaplasma, which is with a lady in Portland, Oregon, and she's got a ureaplasma model. Ureaplasma is the most common bacteria causing ruptured membranes preterm labor in humans. And what she's doing is giving an antibiotic targeting that in combination with this BSCI. And the aim in our minds is that we know even if we treat an infection, it won't necessarily stop the preterm labor, and nor will it stop the inflammation causing damage in the baby. So we hope this anti-inflammatory BSCI will enable us, A, to stop it, the preterm labor, and B, protect the baby, which is the key thing, and which is why Steve Lai's work in Toronto, looking at the long-term outcomes in the pups that have been treated, is really critically important.
And that's what all the FDA is, that you have to, and quite rightly, you have to go through one hoop after the other. So that's what he's doing. It was in North America. So we've got 2 studies, as you say, 2 studies operating with some potentially good inhibitors of preterm birth. So we know there's a mechanism behind infection and premature birth. And with an anti-inflammatory and this drug, it might work. So we're keeping different lines of investigation going. You can't be too careful in the way you do it, and I think that's the responsibility that people like Mark and myself have. That's why we have this rigorous procedure of excluding anything but the best, because you can do work, and there's so much. There has to be said. There's an awful lot of clinical research that it isn't repeatable, that gives false hope. But that's because it's not been well done, so you can't actually believe in it. And the literature, I'm afraid, is completely muddled by all of this sort of grey science where you don't know it goes one way or the other. It is absolutely essential to keep that standard right up.
You need evidence
all the way through, because it's a waste of money otherwise.
Do you ever get absolute charlatans rocking up going, I'm going to give 25 women 20 fags a day and see what happens?
Oh, we have a few. We have a few applications like that. Not far off the
truth. Do you know, I remember actually when I was in hospital, I couldn't find literature that was helpful. So I went down the route of going and looking at really, really, really old literature. We're talking sort of decades back, to find that when women went into preterm labour to keep the womb quiet, they used to administer alcohol.
Did they? They did.
Wow. They did. To keep the womb
intravenous alcohol.
Intravenous alcohol.
Really?
Well, I don't know.
I've not been that far back.
No, and I was like,
well, intravenous? What, you mean they injected them with vodka? I mean, we all did things at university, but that's quite extreme.
Yeah, that seems to take it right to the edge. But it was extraordinary how, so when you take...
What people tried to do.
What people tried to do, they were desperate. They were desperate to keep the womb quiet. And when I went in with my son, who's now just turned 22, I should add, it all felt very worth it. But it didn't make me feel particularly well. And you're sort of...
I don't think we gave you alcohol, did we?
No, you definitely didn't give me alcohol.
I thought you asked me to, but I said no.
Yeah, I did a tonic. My heart rate went incredibly high at one stage, and I remember not being able to see very much because the sweat was incredible. And I do remember this really lovely young doctor, and I was just trying to persuade her. I was like, just give me a little bit more. It's like, I can't. But you're pretty desperate at that stage. Yeah. But I just think, when I talked in terms at the beginning of how far have we come that far in a couple of decades, we're clearly making huge progress.
Strides forward.
Like you've explained, it's so complex. It is so complex. It's not just about the cost of it. Yeah. One pathway opens up another pathway, opens up another pathway, opens up another pathway, and it's sort of a never-ending network. Yeah. And that really is
incremental, and it's quite difficult for us sometimes to stand back from it, as scientists, and think,
zoom out.
Gosh, think how much has happened in our lifetime. I mean, only how many years ago we started giving steroids to women at risk of preterm birth? It wasn't that long ago, and that was from this guy in New Zealand who had sheep who were being frightened by dogs, and he realised that when the sheep delivered early, they were perfectly all right, the lambs, and he couldn't understand why. Then he realised that it was cortisol in the sheep that was keeping the lambs alive. I mean, that was an amazing discovery. I met him. I mean, have you met
Monty Liggins? No, I didn't meet him
met
ever,
him just
sadly.
Shortly before he died. Absolutely wonderful, very modest guy. And then he realised that, this was stimulation of that pathway, the cortisol pathway must be, and that's where it all started. And he went off and did a trial and found that if you gave these corticoid steroids to women in preterm birth, the babies could breathe when they came out. And so
Think of the impact of that. No.
That's had a massive impact.
Absolutely.
But of course, the downside of that is they may still be born, they are still born prematurely. And then you don't know what the consequences of that are going to be. So babies survive who wouldn't have survived previously. And they downstream may have complications. They're born okay, their lungs are okay, but neurodevelopment's a problem. And another problem, as Mark will tell you, is that you can't tell when a newborn baby is premature what the long-term consequences are going to be by looking at it.
And again, that was a big shock for me. That was something I didn't know about, because again, I just watched a lot of Holby City, and in Holby City, someone goes, I've got this problem, and the doctor goes, this is what's going to probably happen to you. And I thought, that's how medicine works, isn't it? No, I don't need to tell you, that's not how it works at all. So I would be saying, is my baby going to have brain damage, or are they going to have hearing problems or be blind? And the doctors were just like, we don't know, which obviously was the correct and true answer. But that was really terrifying to be sort of hit with that. And they said, we might not know for years. And I was like...
And we still don't know, really. I mean, there's at the hospital I work at St Thomas's, they have a big MRI program they have had over the last few years, looking at the baby's brains that were born prematurely and see if they can see structural differences which will predict what the outcomes are going to be. But they haven't got that far yet. They've got all the scans, hundreds of scans of babies' brains who are born prematurely.
But they're following up the children.
Well, they're following up the children with time to see how they're related to their neurodevelopment. And that, that initial scan might give you some indication of how bad or how good they're going to be in terms of their neurological function. But that's the sort of thing that needs to be done. These scans are incredibly detailed. They're absolutely amazing to look at. They've worked out how all the neurons in the brain are connected, and how they as the baby matures normally, how they will start connecting up. Just amazing. And then they look at the premature children and see if their brain cells connect up in a similar way or not. And that's what they're doing. So that's one way. Ultimately, you might be able to do an MRI scan of a neonate and be able to find out whether they're going to be neurologically affected. I mean, the problem about that is, what do you do about it? Because you can't actually intervene to prevent it.
Yeah, but you can have interventions. For example, the DHA, which is potentially promoting neural maturation.
There are other drugs en route for premature babies and
And there's that 20-hydroxysterol, which comes from breast milk.
Yeah.
And they show putting that in a mouse experiment again, but you make neural stem cells differentiate into the oligodendrocytes, which basically surround your nerves and get them to function better. And so in preterm babes, you have areas of the brain which are deprived of these cells. So giving mothers that seems to help in mice models, and who knows, it's a product of breast milk.
I work with a paediatrician who's looking at 2 new drugs which seem to help in animal studies. They use pigs in those studies, and they seem to be preventing neurological damage when the brain's been starved of oxygen in delivery, but also in premature birth. So there are drugs en route there. It would be interesting to see. But that's the sort of thing, ultimately, if you knew you had a baby at risk, and then you could administer those drugs to the child. So lots of work going on in that area, actually. Yeah.
I mean, the neonatologists are doing far better than we, the obstetricians, are.
They are.
As usual.
So not great news for rats, pigs and mice, but great news for
science, it could be for the right
for humanity.
We know what works in rats, pigs and mice.
Yeah. But it's not exactly the same as humans, right? So we still need to
absolutely right.
Yeah.
Pigs are a good
model,
difference.
They've always used them
because they're born in the same sort of maturity.
Yeah. But what's reassuring is if it doesn't cause problems in these animal studies, which is essential, we can then move into human studies with confidence that we're not going to cause harm. And we've got to do that. That's as much as we all dislike it. Yeah. Animal research, it's essential. I mean, the FDA will not allow us to do studies in humans unless we've gone through 2 animal models.
And is that studies where you're giving humans a drug or a food, or is that...
Well, if we wanted to use a drug to prevent preterm labour, then we would have had to have trialled that drug in animal studies.
Right.
There's a lot of interest in having these organs in a chip. Yep. You can grow sort of organs with different layers of different cells together. There is a lot of interest in using them to be able to test drugs. It's getting there, but it's not there yet. But they're quite useful for drug screening. If you've got something which you know is a genetic disorder and you put that in the cells in the dish, then if you had something which was a potential inhibitor of that particular gene or whatever it is, that would be good. So you could use it for screening drugs when you have a really good model of the problem. So we don't have prematurity in a dish at the moment. But there is a lot of potential in that, but it's not going to replace yet. It's not going to replace doing good studies on animals, mammals, the whole animal, obviously.
Of course.
But there is a big move in that direction, especially in the UK. There is a lot of focus on it.
The same in the NIH. Yeah. They're investing lots and lots of money in it. But I just hope that actually they work.
They probably will get repent. I mean, I remember they didn't exist at all. And
no.
I mean, I was on the Wellcome Trust board. We used to see a lot of these studies coming through, and they were sort of futuristic. But actually, they did work to a degree. They were just developing those organ models on as they say, on a chip in a petri dish, basically. And they do just demonstrate. I mean, you can grow skin, you can grow all the layers of skin, you can demonstrate that absolutely perfect from stem cells. But going that step forward to testing drugs is probably the future if we get it right, but it's not there yet.
And probably a screen test where you can screen multiple.
Yeah, you can screen multiple drugs.
And then choose the best
one.
one.
The use is going to be for. Best.
Aren't we lucky to have you?
Definitely.
Very lucky to have you. It's absolutely extraordinary.
It's a fascinating world. I mean, I think Mark and I have never been bored.
No.
I have never been bored with my work, and I can say that over, it was a long time since I started, but no 2 years are the same. Keeping up with the science is the problem. It is evolving so fast. Technology we're going to be using in this new big project with Borne is super important and very, very complex, but completely new. And we've already shown that a lot of these technologies work in the preliminary work we've done, so we're going to go on and use them in a great big study. But it's just so that we can look at individual cells and how they interact with other cells in the womb, and we couldn't do this before. I mean, we rely on the technology development by other people. We don't actually do the technology development. We have to
You move with it.
We use it when other people have developed it, and that's generally in industry.
I mean, you talked about research studies and looking at people who will assist you with that as being hungry and relatively new, but you both still have that hunger. I mean, that's really clear. So
we can't do this. Has to be said. We had to do this transcriptomics or something. We wouldn't be very good at it, would we?
No,
Mark?
we wouldn't.
So we employ people who know those new technologies. The young people, the people who've been brought up in the labs where they've been working with it, and they're the people that we bring in to actually do that.
And the bioinformaticians who actually interpret it all and put it all into sense.
Who?
Bioinformaticians. I mean, the amount of data you generate from these studies is enormous.
The big issue in science now is that, I mean, to do these studies, you often outsource it to commercial sector or another laboratory or whatever. You just end up with shed loads of data, massive computers you need. And a lot of it is just analysing it in the way how the data overlaps and how you integrate it, how you understand it. And these bioinformaticians are data scientists who work in biology, and we need them big time.
You need those pattern seekers.
Most important in now than we never need them like we do now. They're like hen's teeth. We can't get them. There's such demand for bioinformatics in medicine, medical research now and of course industry sweeps them all up, pays them more than we can. But those people are the ones that we need to grow. As part of our new research is going to be growing up a bump team, a Borne team of bioinformaticians.
I mean, we've almost got through a whole episode of a podcast about mentioning AI, but here we go.
There we go.
And is there a role for AI, do you think, in if not processing that data, then doing something
processing
else?
the data, and we're looking for pathways. I mean, AI itself is not actually very new. I mean, we've always done looking at pathway recognition by just algorithms of longitudinal type, but it's just that the computing ability is so much greater now. So it always used to be done by the human brain and the old computer, but now the computing just does it in shed loads. It's just extraordinary. So everybody's using this in bioinformatics, and we've used it in some of our population health data recently, and it just does it more quickly for you, and it does it in enormous depth and accuracy. So AI in that respect is just fantastic. So these bioinformaticians will be using AI.
Without it, it would hold you back.
Yes, it would. I mean, it's just part of the scene now. You don't think twice about it, really. It's the way it's going to work in the future.
I mean, it's incredible. Science is amazing. Isn't it? It's amazing.
For more information on the work of the Borne Foundation and how you can help the charity save babies' lives, please visit www.borne.org.uk or follow the links in the podcast notes. The Borne Podcast is presented by Ellie Gibson, Caro and Professor Mark Johnson. The music is by Kirsty Newton, and it is produced by Laura Grimshaw.